Worldwide recognition of the catastrophic effects of climate change led in late 2015 to a historic meeting of 196 countries in Paris, France, at which the participating countries agreed to the following objective: halting the increase in the global average temperature to well below 2 degrees centigrade above pre-industrial levels, and to pursue efforts to limit the temperature increase to 1.5 degree centigrade above pre-industrial levels, recognizing that this would significantly reduce the risks and impacts of climate change. Toxicology is defined as the science of poisons. It studies the distributions, effects, and mechanism of action of toxic agents. More broadly, it also includes the study of the effects of physical agents such as radiation and heat. Approximately 4 billion pounds of toxic chemicals, including 72 million pounds of known carcinogens, are produced each year in the United States. In general, however, little is known about the potential health effects of chemicals. Of the approximately 100,000 chemicals in use in the United States, less than 1% have been tested experimentally for health effects. We now will talk about some basic principles regarding the toxicity of exogenous chemicals and drugs. The definition of a poison is not straightforward. It is a quantitative concept, strictly dependent on dosage. The quote from Paracelsus in the 16th century that all substances are poisons, the right dosage differentiates as a poison from a remedy, is perhaps even more valid today in view of the proliferation of therapeutic drugs with potentially harmful effects. Xenobiotics are exogenous chemicals in the environment that may be absorbed by the body through inhalation, ingestion, or skin contact. On the picture you see the changes in chemical reactivity and excretability with metabolism. Chemicals may be excreted in urine or feces or eliminated in expired air, or they may accumulate in bone, fat, brain, or other tissues. Chemicals may act at the site of entry, or they may be transported to other sites. Some agents are not modified on entry in the body, but most solvents and drugs are metabolized to form water-soluble products, known as detoxification, or also are activated to form toxic metabolites. Most solvents and drugs are lipophilic, which facilitates their transport in the blood by lipoproteins and penetration through lipid components of cell membranes, as could be seen on the picture. The reactions that metabolize xenobiotics into non-toxic products or activate xenobiotics to generate toxic compounds, as shown on the picture, occur in two phases. In phase 1 reactions, chemicals can undergo hydrolysis, oxidation, or reduction. Products of phase 1 reactions often are metabolized into water-soluble compounds through phase 2 reactions of glucuronidation, sulfation, methylation, and conjugation with glutathione. Water-soluble compounds are readily excreted. The most important cellular enzyme system involved in phase 1 reactions is the cytochrome P450 system. The P450 system is present in organs throughout the body, but it is most active in the endoplasmic reticulum of the liver. The P450 enzymes vary widely in activity among different people, owing to both polymorphisms in the gene encoding the enzymes and interactions with drugs that are metabolized through the system. The activity of the enzymes also may be decreased by fasting or starvation and increased by alcohol consumption and smoking. The system catalyzes reactions that may either detoxify xenobiotics or convert xenobiotics into active compounds that cause cellular injury. Both types of reactions may produce, as a byproduct, reactive oxygen species, which can cause cellular damage. Examples of metabolic activation of chemicals through the P450 system are the conversion of carbon tetrachloride to the toxic trichloromethyl free radical and the generation of a DNA-binding metabolite from benzopyrene, a carcinogen present in cigarette smoking. The cytochrome P450 system also participates in the metabolism of a large number of common therapeutic drugs such as acetaminophen, barbiturates, and anticonvulsants, and in alcohol metabolism. Air pollution is a significant cause of morbidity and mortality worldwide, particularly among at-risk individuals with pre-existing pulmonary or cardiac disease. The life-giving air that we breathe is also often laden with many potential causes of disease. Airborne microorganisms have long been major causes of morbidity and death. More widespread are the chemical and particulate pollutants found in the air, both in so-called developed and underdeveloped countries. Specific hazards have been recognized for both outdoor and indoor air. The ambient air in industrialized nations is contaminated with an unsavory mixture of gaseous and particulate pollutants, more so in cities and in proximity to heavy industry. In the United States, the Environmental Protection Agency monitors and sets allowable upper limits for 6 pollutants: sulfur dioxide, carbon monoxide, ozone, nitrogen dioxide, lead, and particulate matter. Together, some of these agents produce the well-known smog that sometimes stifles major cities such as Cairo, Los Angeles, Houston, Mexico City, Sao Paulo, and Almaty. It may seem that air pollution is a modern phenomenon. This is not the case. Seneca wrote in AD 61 that he felt an alteration of his disposition as soon as he left the pestilential vapors, soot, and heavy air of Rome. The first environmental control law was proclaimed by Edward I in 1306 and was straightforward in its simplicity. Whoever should be found guilty of burning coal shall suffer the loss of his head. What has changed in modern times is the nature and sources of air pollutants and the type of regulation that control their emission. It could be argued that modern man has lost his head to drown himself in pollution. The lungs bear the brunt of the adverse consequences of air pollution, but air pollutants affect many organ systems, as with the effects of lead poisoning and carbon monoxide. Here, we will consider the major health effects of ozone, sulfur dioxide, particulates, and carbon monoxide. Ozone is one of the most pervasive air pollutants, with levels in many cities exceeding Environmental Protection Agency standards. It is a gas formed by sunlight-driven reactions involving nitrogen oxides, which are released mostly by automobile exhaust. Together with oxides and fine particulate matter, ozone forms the familiar smoke, which is a combination of word smoke and fog. Its toxicity stems from its participation in chemical reactions that generate free radicals, which injure the lining cells of the respiratory tract and the alveoli. Low levels of ozone may be tolerated by healthy persons but are detrimental to lung function, especially in those with asthma or emphysema, and when present along with particulate pollution. Unfortunately, pollutants rarely occur singly but combine to create a veritable witch's brew. Sulfur dioxide particles and acid aerosols are emitted by coal and oil-fired power plants and industrial processes burning these fuels. of these, particles appear to be the main cause of morbidity and death. Particles less small in diameter are particularly harmful because when inhaled, they are carried by the airstream all the way to the alveoli. Here they are phagocytized by macrophages and neutrophils, causing the release of mediators, possibly by activating inflammasomes and inciting an inflammatory reaction. By contrast, larger particles are removed in the nose or are trapped by the mucociliary escalator and as a result are less dangerous. Carbon monoxide is a non-irritating, colorless, tasteless, odorless gas. It is produced by the incomplete oxidation of carbonaceous materials. Its sources include automotive engines, industries using fossil fuels, home oil burners, and cigarette smoke. The low level often found in ambient air may contribute to impaired respiratory function, but usually are not life-threatening. However, persons working in confined environments with high exposure to fumes, such as tunnel and underground garage workers, may develop chronic poisoning. Carbon monoxide is included here as an air pollutant, but it also is an important cause of accidental and suicidal death. In a small closed garage, exhaust from a running car engine can induce a lethal coma within 5 minutes. Carbon monoxide is a systemic asphyxiant that kills by binding to hemoglobin and preventing oxygen transport. Hemoglobin has a 200-fold greater affinity for carbon monoxide than for oxygen. The carboxyhemoglobin that is formed by binding of carbon monoxide is incapable of carrying oxygen. Hypoxia leads to central nervous system depression, which develops so insidiously that victims often are unaware of their plight and are unable to help themselves. Systemic hypoxia appears when the hemoglobin is 20 to 30% saturated with carbon monoxide, and unconsciousness and death are probable with 60 to 70% saturation. The diagnosis of carbon monoxide poisoning is based on detection of high levels of carboxyhemoglobin in the blood. Chronic poisoning by carbon monoxide develops because carboxyhemoglobin, once formed, is remarkably stable. As a result, with low-level persistent exposure to carbon monoxide, carboxyhemoglobin may accumulate to a life-threatening concentration in the blood. The slowly developing hypoxia can evoke widespread ischemic changes in the brain, particularly in the basal ganglia and lenticular nuclei. With cessation of exposure to carbon monoxide, the patient usually recovers, but there may be permanent neurological damage. Acute poisoning by carbon monoxide generally is a consequence of accidental exposure or suicide attempt. In light-skinned people, it is marked by a characteristic generalized cherry red color of the skin and mucous membranes, a color imparted by carboxyhemoglobin. If death occurs rapidly, morphologic changes may not be present. With longer survival, the brain may be slightly edematous and exhibit punctured hemorrhages and hypoxia-induced neuronal changes. These changes are not specific, they simply imply systemic hypoxia. In victims who survive carbon monoxide poisoning, complete recovery is possible. However, impairments of memory, vision, hearing, and speech sometimes remain. As modern homes are increasingly buttoned up to exclude the environment, the potential for pollution of the indoor air increases. The most common pollutant is tobacco smoke, but additional offenders are carbon monoxide, nitrogen dioxide, and asbestos. Smoke from burning of organic materials containing various oxides of nitrogen and carbon particulates is an irritant that predisposes exposed persons to lung infections and may contain carcinogenic polysaccharides cyclic hydrocarbons. It is estimated that 1/3 of the world, mainly in developing areas, burn carbon-containing materials such as wood, dung, or charcoal in their homes for cooking, heating, and light. Radon, a radioactive gas derived from uranium, is a widely present element in soil and in homes. Although radon exposure can cause lung cancer in uranium miners, it does not appear that low-level chronic exposures in the home increase lung cancer risks, at least for non-smokers. Bioaerosols may contain pathogenic microbiologic agents, such as those that can cause Legionnaire disease, viral pneumonia, and the common cold, as well as allergens derived from pet dander, dust mites, and fungi and molds, which can cause rhinitis, eye irritation, and even asthma. In a summary, it could be said that environmental diseases are conditions caused by exposure to chemical or physical agents in the ambient, workplace, and personal environments. Exogenous chemicals known as xenobiotics enter the body through inhalation, ingestion, and skin contact, and can either be eliminated or accumulate in fat, bone, brain, and other tissues. Xenobiotics can be converted into non-toxic products or toxic compounds through a two-phase reaction process that involves the cytochrome P450 system. The most common air pollutants are ozone, sulfur dioxide, acid aerosols, and particles small in diameter. Carbon monoxide is an air pollutant and an important cause of death from accidents and suicides. It binds hemoglobin with high affinity, leading to systemic asphyxiation, resulting in the central nervous system depression. Tobacco is the most common exogenous cause of human cancers, being responsible for a huge percentage of lung cancers. The main culprit is cigarette smoking, but smokeless tobacco in its various forms, snuff, chewing tobacco, also is harmful to health and is an important cause of oral cancer. Not only does the use of tobacco products create personal risks, but also passive tobacco inhalation from the environment can cause lung cancer in non-smokers. From 1998 to 2007 in the United States, the incidence of smoking declined modestly, but this trend failed to continue, and approximately 20% of adults remain smokers. In recent years, China has become the world's largest producer and consumer of cigarettes. China has approximately 350 million smokers, with an aggregate consume about $33 of all cigarettes smoked. 33% of all cigarettes smoked worldwide. Cigarette smoking causes more than 4 million deaths annually, mostly from cardiovascular disease, various types of cancers, and chronic respiratory problems. It is expected that there will be 8 million tobacco-related deaths only by 2020, the major increase occurring in developing countries. Of people alive today, an estimated 500 million will die from tobacco-related illnesses. In the United States alone, tobacco is responsible for more than 400,000 deaths per year, with 1/3 of these attributable to lung cancer. Smoking is the most important cause of preventable human death. It reduces overall survival in a dose-dependent fashion. Whereas 80% of non-smokers are alive at age 70, only about 50% of smokers survive to this age. Cessation of smoking greatly reduces the risk of death from lung cancer and even has an effect, albeit reduced, on people who stop smoking at age 60. We'll discuss some of the agents contained in tobacco and diseases associated with tobacco consumption. The number of potentially noxious chemicals in tobacco smoke is vast. On the picture present, only a partial list, and it includes the type of injury produced by these agents. Nicotine, an alkaloid present in tobacco leaves, is not a direct cause of tobacco-related diseases, but it is highly addictive. Nicotine binds to receptors in the brain and through the release of catecholamines is responsible for the acute effects of smoking, such as increased heart rate and blood pressure and increased cardiac contractility and output. The most common diseases caused by cigarette smoking involve the lung and include emphysema, chronic bronchitis, and lung cancer. The mechanisms responsible for some tobacco-induced diseases include the following: direct irritant effect on the tracheobronchial mucosa, carcinogenesis, atherosclerosis, maternal smoking increases the risk of spontaneous abortions and preterm births, and passive smoke inhalation. Direct irritant effect on the tracheobronchial mucosa, producing inflammation and increased mucus production, is shown on the picture. Cigarette smoke also causes the recruitment of leukocytes to the lung, increasing local elastase production and subsequent injury to lung tissue that leads to emphysema. Components of cigarette smoke, particularly polycyclic hydrocarbons and nitrosamines, are potent carcinogens in animals and probably are involved in causation of lung carcinomas in humans. The risk of developing lung cancer is related to the intensity of exposure, frequently expressed in terms of pack years, meaning 1 pack daily for 20 years equals for 20 pack years. Or it is also counted in cigarettes smoked per day. For example, the risk of lung cancer is determined by the number of cigarettes smoked. In addition to lung cancers, tobacco smoke contributes to the development of cancers of the oral cavity, esophagus, pancreas, and bladder. Smoking multiplies the risk of disease associated with other carcinogens. Well-recognized examples are the tenfold increased incidence of lung carcinomas in asbestos workers and uranium miners who smoke than in those who do not. The combination of tobacco, both chewed and smoked, and alcohol consumption has a multiplicative effect on the risks of your oral, laryngeal, and esophageal cancers. An example of the carcinogenic interaction of these all too common vices is shown for laryngeal cancer. Atherosclerosis and its major complication, myocardial infarction, are strongly linked to cigarette smoking. The causal mechanisms probably relate to several factors, including increased platelet aggregation, decreased myocardial oxygen supply, accompanied by increased oxygen demand and decreased threshold for ventricular fibrillation. Almost 1/3 of all heart attacks are associated with cigarette smoking. Smoking has a multiplicative effect on risk when combined with hypertension and hypercholesterolemia. Maternal smoking increases the risk of spontaneous abortions and preterm births and results in intrauterine growth retardation. However, birth weight of infants born to mothers who stopped smoking before pregnancy are normal. Passive smoke inhalation is also associated with detrimental effects as shown on the picture. It is estimated that the relative risk of lung cancer in non-smokers exposed to environmental smoke is about 1.3 times than that of in non-smokers who are not exposed to smoke. In the United States, approximately 3,000 lung cancer deaths in non-smokers older than 35 years can be attributed each year to environmental tobacco smoke. Even more striking is the increased risk of coronary atherosclerosis and fatal myocardial infarction. Studies report that 30,000 to 60,000 cardiac deaths annually in the United States are associated with passive exposure to smoke. Children living in a household with an adult who smokes have an increased frequency of respiratory illnesses and asthma. Passive smoke inhalation in non-smokers can be estimated by measuring the blood levels of cotinine and a metabolite of nicotine. In the United States, median nicotinine levels in non-smokers have decreased by more than 60% since around 2000 because of the adoption of non-smoking policies in public places. However, passive exposure to tobacco smoke in the home remains a major public health concern, particularly for children. It is clear that a transient pleasure a puff may provide comes with a heavy long-term price. Smoking is the most preventable cause of human death. Tobacco smoke contains more than 2,000 compounds. Among these are nicotine, which is responsible for tobacco addiction, and strong carcinogens, mainly polycyclic aromatic hydrocarbons, nitrosamines, and aromatic amines. Approximately 90% of lung cancers occurs in smokers. Smoking is also associated with an increased risk of cancers of the oral cavity, larynx, esophagus, stomach, bladder, kidney, as well as some forms of leukemia. Cessation of smoking reduces the risk of lung cancer. Smokeless tobacco use is an important cause of oral cancers. Tobacco interacts with alcohol in multiplying the risk of oral, laryngeal, and esophageal cancer and increases the risk of lung cancers from occupational exposures to asbestos, uranium, and other agents. Tobacco consumption is an important risk factor for development of atherosclerosis and myocardial infarction, peripheral vascular disease, and cerebrovascular disease. In the lungs, in addition to cancer, it predisposes to emphysema, chronic bronchitis, and chronic obstructive disease. Maternal smoking increases the risk of abortion, premature birth, and intrauterine growth retardation. Ethanol is consumed at least partially for its mood-altering properties, but when used in moderation, its effects are socially acceptable and not injurious. When excessive amounts are used, alcohol can cause marked physical and physiological damage. Today we will discuss the lesions that are directly associated with the abuse of alcohol. Despite all the attention given to illegal drugs, alcohol abuse is a more widespread hazard and claims many more lives. 50% of adults in the Western world drink alcohol, and approximately 5% to 10% have chronic alcoholism. It is estimated that there are more than 10 million chronic alcoholics in the United States and that alcohol consumption is responsible for more than 100,000 deaths annually. Almost 50% of these deaths result from accidents caused by drunken driving and alcohol-related homicides and suicides, and about 15% are the consequence of cirrhosis of the liver. After consumption, ethanol is absorbed unaltered in the stomach and small intestine, and then distributes to all the tissues and fluids of the body in direct proportion to the blood level. Less than 10% is excreted unchanged in the urine, sweat, and breath. The amount exhaled is proportional to the blood level and forms the basis for the breath test used by law enforcement agencies. A concentration of 80 milligrams per deciliter in the blood constitutes the legal definition of drunk driving in most states. For an average individual, this alcohol concentration may be reached after consumption of 3 standard drinks. About 3 bottles of beer, 15 ounces of wine, or 4 to 5 ounces of distilled spirits. Drowsiness accrues at 200, stupor at 300, and coma with possible respiratory arrest at higher levels. The rate of metabolism affects the blood alcohol level. Chronic alcoholics develop tolerance to alcohol. They metabolize alcohol at a higher rate than normal and hence show lower peak levels of alcohol than average for the same amount of alcohol consumed. Most of the alcohol in the blood is metabolized to acetaldehyde in the liver by 3 enzyme systems: alcohol, dehydrogenase, cytochrome P450, isoenzymes, and catalase, as on the picture. Of these, the main enzyme involved in alcohol metabolism is alcohol hydrogenase located in the cytosol of hepatocytes. At high blood alcohol levels, however, the microsomal ethanol oxidizing system also plays an important role. This system involves cytochrome P450 enzymes, particularly the CYP2E1 isoform located in the smooth reticulum. Induction of P450 enzymes by alcohol explains the increased susceptibility of alcoholics to other compounds metabolized by the same enzyme system, which includes drugs, anesthetics, carcinogens, and industrial solvents. Of note, however, when alcohol is present in the blood at high concentrations, it competes with other CYP2E1 substrates and may delay the catabolism of other drugs, thereby potentiating their effects. Catalase is of minor importance, being responsible for only about 5% of alcohol metabolism. Acetaldehyde produced by the system is in turn converted to acetaldehyde dehydrogenase to acetate, which is used in the mitochondrial respiratory channel. Acute alcoholism exerts its effects mainly on the central nervous system, but also may include reversible hepatic and gastric injuries. Even with moderate intake of alcohol, multiple fat droplets accumulate in the cytoplasm of hepatocytes. Gastric damage occurs in the form of acute gastritis and ulceration. In the central nervous system, alcohol is a depressant, first affecting subcortical structures that modulate cerebral cortical activity. Consequently, there is stimulation and disordered cortical motor and intellectual behavior. At progressively higher blood levels, cortical neurons and then lower medullary centers are depressed, including those that regulate respiration. Respiratory arrest may follow. Chronic alcoholism affects not only the liver and stomach, but virtually all other organs and tissues. Chronic alcoholics suffer significant morbidity and have a shortened lifespan related principally to damage to the liver, gastrointestinal tract, central nervous system, cardiovascular system, and pancreas. The liver is the main site of chronic injury. In addition to fatty change mentioned earlier, chronic alcoholism causes alcoholic hepatitis and cirrhosis. Cirrhosis is associated with portal hypertension and increased risk of hepatocellular carcinoma. In the gastrointestinal tract, chronic alcoholism can cause massive bleeding from gastritis, gastric ulcer, and esophageal varices, which may prove fatal. Thiamine deficiency is common in chronic alcoholics. The principal lesion resulting from the deficiency are peripheral neuropathies and the Wernicke-Korsakoff syndrome. Cerebral atrophy, cerebellar degeneration, and optic neuropathy may also occur. Alcohol has diverse effects on the cardiovascular system. Injury to the myocardium may produce dilated congestive cardiomyopathy. Moderate amounts of alcohol, 1 drink per day, have been reported to increase serum levels of high-density lipoproteins and inhibit platelet aggregation, therefore protecting against coronary artery disease. However, heavy consumption with attendant liver injury results in decreased level of high-density lipoproteins, increasing the likelihood of heart disease. Chronic alcoholism also is associated with an increased incidence of hypertension. Excess alcohol intake increases the risk of acute and chronic pancreatitis. The use of ethanol during pregnancy, reportedly even in low amounts, can cause fetal alcohol syndrome. It consists of microcephaly, growth retardation, and facial abnormalities in the newborn and a reduction of mental functions in older children. It is difficult to establish the amount of alcohol consumption that can cause fetal alcohol syndrome, but consumption during the first trimester of pregnancy is particularly harmful. Chronic alcohol consumption is associated with an increased incidence of cancers of the oral cavity, esophagus, liver, and possibly breast in females. The mechanisms of their carcinogenic effect are uncertain. Ethanol is a substantial source of energy, but is often consumed at the expense of food. Chronic alcoholism is therefore associated with malnutrition and deficiencies, particularly of the B vitamins. Acute alcohol abuse causes drowsiness at blood level of approximately 200 milligrams per deciliter. Stupor and coma develop at higher levels. Alcohol is oxidized to acetaldehyde in the liver primarily by alcohol dehydrogenase and to a less extent by the cytochrome P450 system and by catalase. Acetaldehyde is converted to acetate in mitochondria and used in the respiratory chain. The main effects of chronic alcoholism are fatty liver, alcoholic hepatitis, and cirrhosis, which leads to portal hypertension and increases the risk for development of hepatocellular carcinoma. Chronic alcoholism can cause bleeding from gastritis and gastric ulcers, peripheral neuropathy associated with thiamine deficiency, and alcoholic cardiomyopathy, and it increases the risk for development of acute and chronic pancreatitis. Chronic alcoholism is a major risk factor for cancers of the oral cavity, larynx, and esophagus. The risk is greatly increased by concurrent smoking or the use of smokeless tobacco.